¿Te conectaste, Leonardo? No, Leonardo, conéctate, por favor. Vas a tener todo apagado, pues. Pero creo que estás ahí. El problema en México son 6 de la mañana. Mexicano se levanta tarde.
Oh, Leonardo.
Yeah.
Okay. Alessis Fernando Ramirez.
Yes, I am.
Hay otro Leonardo, su hermano.
It's my son.
Su
Es mi
hijo.
hijo. Es mi hijo.
Está
residente
estudiando español, está estudiando medicina.
Es residente de neurocirugía.
¿En dónde?
Invítame, dile que me invite.
México.
Oh, hola. ¿Quiere hablar, Leonardo? ¿Quiere hablar?
Me tiene que invitar. Que me tiene que invitar.
Vale,
Hola,
vale.
hola, Luis.
Invítame.
Sí.
Me hice nuevo panelista, ya está.
Como panelista, profesor.
Ya,
Sí, la gente va a venir.
ya estoy.
Ah, qué bueno.
Oye, mira.
El hombre central.
Mira.
Oh, no, para desayuno.
No, Vega Sicilia. El mejor
bueno.
vino de España.
Oh, sí.
$1000.
Wow.
Enséñaselo a Pascal Jabur.
Wow.
Doctor Ibor Lopez hace webinar con Vega Sicilia.
Sí.
Míralo, ¿eh?
Sí, qué bueno. Qué lástima, yo no tomo.
Y mi hija, la que me ayuda.
Ah, qué bonita. Wow.
Good afternoon.
De Reinaldo.
En medicina.
Bueno, todo bien, ¿no?
Okay, hey, hola. No sé cómo te llama. Hay dos chinesas. Qué bueno. Déjame.
Ahí hay un chino.
Okay,
Binsu está ahí.
Dos chinos. El Ben está aquí.
Empiezo yo, 10 minutos, y todo el resto para Bin.
Sí, 5 minutos más o menos.
No, yo
sí,
10.
es noche en España.
No, en España es 2 de la tarde.
Oh, ok.
Noche en Shanghái.
Hola, Ben.
Hello, John.
Nice to see you.
Hello, professor.
Hi, Luis.
Hi, professor. You are very happy. Look that. This is the best wine in Spain.
Oh.
Vega Sicilia.
Ah.
Next time you come to Madrid, I send you one bottle. Okay?
Oh, great. Thank you.
It's a special one.
Hey, recuerda, Ben, la primera vez que fui a visitar Luis es por...
English.
En inglés.
Yes.
Sí, Televisa de China, Congreso de Luis. ¿Recuerda
Well, you
esto?
speak English with Bean. With
Oh.
Bean.
Oh, okay.
Repeat. Do you remember the first time I come to the meeting of Luis in Madrid?
Yes.
John Bennett is a good guy.
Es
Yes.
mi favorito congreso de todo, España. Fui al Prado para visitar la ciudad.
Flamenco.
Sí, muy bueno. Y Flamengo fue muy bien, congreso. Complete. Rinaldo, completa. Luis.
Perfecto.
Hi, Rinaldo.
All right, Professor. If you want, I present this topic when you want we can to begin. I am ready.
Okay, but it's Bennett because Bennett connect to Neurosurgical TV.
All right.
It is
I need
5, 4.
Oh yeah, with the TV. I need the advice on time to present that.
Como Hollywood or television.
Como Hollywood, igual. Pero no, ¿cómo se llama este? El de Tampa. Walt Disney, no.
Walt Disney, no.
Not, I don't like Walt Disney.
I like Walt Disney.
Too much work.
Yes, Professor. You are looking very nice, Professor Luis.
Very nice.
Very yeah, very nice.
This is the reason.
Oh, thank you. Oh, coffee from me.
Vega Sicilia.
It's 6 o'clock here in Mexico. I am in Mexico here right now.
Café cubano.
Oh,
Café con barro. And Professor Bean, what drink? You drink summer.
Actually, I also have a visitor from Spain. She's a young female doctor.
What is the name?
Pamplona.
The
Paula.
name? Paula.
Yes. Paula, yes.
Is she going to come? Yeah, she's going to come, Ben?
She will stay in my hospital for 3 months. Yeah.
Okay.
You speak.
And now I have 4 visitors.
You speak with she.
2 from Romania, 1 from Spain, and 1 from Vietnam.
Listen, Bean. You speak with Paola, and you tell my name, and it's very important, doctor. Really?
Soy Paula.
Paola.
Yes.
Paola. You send a message. Doctor Lopez Ibor. It's crazy. Really.
Okay, más gente va a venir, Ben, cuando empiece.
Paula Carlo Alonso.
Paola Alonso, perfecto.
Alonso. Yeah.
Alonso is the same que Chu in Indian. It's popular name, Alonso. Okay.
Okay, vamos a empezar, Luis, okay?
Perfecto.
Okay, 10, 9, 8, 7, espera. Record, okay. 10, 8, 7, 6, 5, 4, 2, 1. Good day, this is Dr. John Bennett, televising from Miami Beach, home of Neurosurgical TV. we have a great webcast with Ben, our old friend from China, who's done lots of webcasts. We did a webcast together, Louis, with Yuha for a couple of years. And that's another story. Ben really treated Yuha well, and they did a lot of teaching in China. And Yuha could have went anywhere in the world, but he came to China with Ben. Anyway, Louis is going to moderate. Louis Lopez Ibor. I've been televising Louis a long time, and I'll turn it over to Louis. Good day, Louis. It's all yours.
How are you? Thank you. Thank you, John.
Okay,
Yeah.
Professor.
Yeah,
So when
go ahead.
I begin the presentation of this topic,
Yes. Reinaldo, go.
Okay. Morning. Thank you for connecting. Welcome back one more time to this new roundtable. Right now with a great guest, Professor Vinshu and Professor Luis Lopez Ibor by NeuroInterventonal. And we had a very, very great topic. We discussed in this time about the cavernous aneurysms. We hope these topics great experience for you, and we had a good discussion. And then Dr. Luis, my professor, my professor is he come a lot of time here Latin America to treat very difficult AVMs and aneurysms. Dr. Luis, please, you are on the floor. We begin with this topic and discussion. Thank you very much.
Okay. Thank you, Reinaldo.
Thank you.
Ramirez Sacon.
I am from Mexico.
Thank you, John, for your channel. Of course, thank you, Professor Binshu. It's an honor you stay in this webinar. I introduce you my idea from this webinar. I work in endovascular procedure about 14 years. I start with Las Juniors in France. Then I live in Madrid, and then I go to Hispanoamerica. In my life, only 5 anastomosis, bypass, external, internal, in my patient. Only 5. And the professor have the procedure is Tuleken, ELANA system, because it's in Holland. Because in Spain, no good expert for this technique. And the idea to this session is I know Professor Binshu, my friend, only have 70,000 bypass. Only 70,000. This man, this doctor. It's okay, no? And this is the reason why I present some case with endovascular. See, I have the Professor Binshu or another expert. Probably many cases is treated by bypass and surgery, not only endovascular. Okay, I present the case. Compartir un momento.
I can say anything. Carotid cavernous aneurysms mainly affect women with a middle age, producing multiple neurological signs and symptoms as diplopia, headache, and more.
Okay, I start. Okay, cavernous aneurysm, endovascular or surgery. It's different approach, but it's the same goal. No? I stand in Paris. I am a friend. Vinko Dolen, stay in my home, or Professor Yasarhil, stay in my home. This is my sister, my brother, my mother, I don't know where it is. Okay. I know the expert of vascular surgery, especially in the cavernous sinus, in general vascular, Professor Yasarhil. I know him. I stayed with him 1 month. Also, for me, it's an honor to know the last best neurovascular surgeon, Juha Hernesniemi. Special, professional, good guy. I learned with him many lessons. At the beginning, 85, 86, I worked in La Salpêtrière with a neurosurgeon and neurologist. This is Professor Charcot. This is La Salpêtrière. Also, at the same time, I work with Pierre Lasunias in Bicêtre. Lasunias is the neuroanatomist, is not radiologist, is not neurosurgeon, is anatomist. I am the first pupil from Pierre. I learned with him the vein of Galen, embolization of the brain AVM, the vein of Galen fistula, spinal cord AVM, and pediatric vascular anomaly. But not bypass, surgical bypass. I present some group of patients. The 90 to 21, I treated 95 patients only with balloon occlusion, test occlusion, and balloon occlusion, and sacrifice the carotid, the paravessel. The procedure, this is the aneurysm, an example. Look the flow, lateral view. The procedure is you place the balloon here, test. If the occlusion test is okay, you wait 20 minutes, you drop the tension, arterial pressure, you drop, and you wait 20 minutes. See the patient is okay, you detach the balloon. This is the balloon, this is the test occlusion, and the detached balloon, thrombus, and control. It's the most simple procedure and the less complication. The last week I talked with, in this webinar with Moret, and discussed the same thing. So you are the possibility to close the paravessel, you are the goal to treat the lesion. I don't know why. Look this, the thrombus is in the vessel. This is angio-CT, totally thrombus, similar flow in the both hemispheres. This is the reason you wait 20 minutes and you drop the pressure. After few months, this decrease and disappear the mass effect. This is another example, the second. Aneurysm. This is not middle cerebral artery. This is superior cerebral artery. Why? Persistent trigeminal artery and the end of the basilar artery. Wow. Where you place the balloon? You place the balloon just after anastomosis trigeminal. Stagnation, vertebrovascular system open, totally closure of the aneurysm. Because the test occlusion in vascular system don't work. It's impossible to test. No, Bishu, his man, it's impossible because the patient is in the bed. Okay. Then my progress, or the progress of the NeuroInterventonal, is coils and stent, soft stent. I think with the small aneurysm, the small, not the giant, not the giant, the small aneurysm is best procedure because don't have many time to go to the aneurysm. It's very easy. This aneurysm is rupture. You are here, the point of rupture. Balloon, stent, coiling, totally occluded ophthalmic artery. I think this is a good treatment. Another example, with balloon, expandable stent, and this is the final control. It's the same example, sorry. This patient I treated about 97. Okay, you see the stent, you are the coil, perfect result. Other patient, this is the stent, the aneurysm is here, is not ophthalmic, is C4 or C2, whatever you want, bilobulated, covered with a stent. And then I push the onyx. Onyx is a material, the high density onyx, the 5000. You are here. This is the cast of onyx. This is the total occlusion in this AP view. Intracerebral stent, not coil, onyx. Another example. I think this small or medium aneurysm is not difficult to the neurosurgeon. It's too hard to work with him. It's too easy with endovascular. And everything, onyx is one of them. I test one of this is important. Another, only onyx, para-ophthalmic bilobulated aneurysm, less than 1 millimeter to the original ophthalmic. This is the balloon, remodeling balloon. This is the catheter in the end of the sac. This is the onyx. And you careful, the reflux in the ophthalmic. Very careful. This is the control, totally occlusion, ophthalmic artery open, lateral view, AP view, ophthalmic, and this is the imaging of croissant around the carotid. You are sure these aneurysms don't regrowth. It's very simple to present. It's very difficult to have this technique. Other aneurysm, AP view, intracavernous aneurysm, lateral view. I treated with onyx, but look that. The cast of onyx look a small part is point of rupture. It's not rupture, this aneurysm. This is the point of possible rupture. It's impossible to see here. But when you inject the onyx, you know this part of the aneurysm is fragile. After total occluded. This, I remember this patient is treated in Mexico by Professor Reinaldo. or Dr. Reynaldo. Aneurysm puts some coils. This is the result. It's not totally occluded, but it's not bad. 3 months later, regrowth the aneurysm. And this is possible surgery, but possible occlusion because you are anastomosis. But for the surgery, it's difficult because you are the coils are round. In this situation, I decided to treat it with complementary treatment with onyx, totally occluded and good result. The onyx for the aneurysm is very nice technique, but very difficult to reproduce to another doctor. It's very difficult technique. This example is giant endocavernous, don't have the anastomosis with AP, anterior communicant artery. Both temporal, I don't have a Professor Binshun at that time. Also have the stenosis, pre-aneurysmatic stenosis. These are 3D, only for this. Balloon, contrast, balloon, close the aneurysm. Onyx, totally occluded without open the anastomose, the anterior communicant artery. Perfect result. This treatment is about 2 hours. In aneurysm with onyx, 28 tests. Giant is 28 and large next in 3. Only one deficit, rupture to have a small silk leak, endolink, and 1 migration 2 meses later. Don't death and don't have a heart complication. 33 patients. Finally, the neuro device is the flow diverter. Everybody thought the flow diverter, blah, 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 is the best thing of the best, blah, blah. Okay. This patient have an intracavernous aneurysm, AP view. This is the 3D to calculate the distance of the diameter of the distal part and the proximal part. This point is important because if you not choose the good size, you are intra flow. You need to deploy the proximal part. The distal part is adaptable. Okay. After the deploy, you see the device, flow diverter, contrast, occur the aneurysm. But when I close the aneurysm with flow diverter, I think, in my opinion, I put some complementary coils. Why? Because it's possible in few days or few weeks you are the regrow the aneurysm because it's very soft stem. This is the reason I put coils at the same time to stabilize the flow diverter. The last case is a 49 woman with multiple aneurysms. I put one surpass flow diverter 4 years later, before. This is the initial aneurysm. I have 4 aneurysms, I think. Ophthalmic, posterior, ophthalmic, treated, then continue. Control in 33, the still open and still open. I decide to treat with coiling both parts, this and this. You are another one here. And 1 year later, in 2004, sorry, I decide to complete the treatment with a surpasses flow diverter. This is the result. Perfect. Nice. Good. But 6 months later, in September, I have a control. And in CT, MR, sorry, you have some spot, the microembol. And it's perfect. Why? Well, I think. Look that. I perform another angio, few minutes later. I check with 3D imaging the flow diverter. It's okay, no? It's not bad, but develop more ischemia, chronic ischemia. 28. What happened? Look that. They are still totally closed, don't worry. But in the 3D angio CT, angio room, you are here, the stenosis in the distal part of the surpass of flow diverter. It's a new stenosis. The patient is well with the anti-aggregation, double aggregation. This is the reason with you are the new technique, you are happy, fantastic, you are good image, but I don't sure the patient is okay. I think the best endovascular treatment is possible is close the parent vessel in the giant. In the medium and small size, endovascular is okay. Giant, sometimes it's not okay. This is the reason why I am invited on this webinar at the top in the world, Professor Binshu, to learn, please, a NeuroInterventional, what is your method to treat this type of patient? Thank you very much. For you. Que empiece.
I can to introduce the Professor Binshu. Okay, thank you, Professor Ruiz. Very, very difficult case. It's a pleasure for me to introduce Professor Binshu. He's a great neurosurgery. He is known as a king of neurosurgery. He is professor of Fundon University, Russian Hospital, and he realized thousands and thousands of bypass. He has a great expertise in Moya disease. Please, Professor Binshu, it's a pleasure. The roundtable is yours right now.
Okay, thank you, Ronaldo. And Professor Luis, you should close your sharing.
Yes, 1 second.
Mm-hmm.
Excuse me. It's okay. It's closed.
Okay. So,
Hey, do you want to put it on presentation mode, Ben? Put it on presentation mode. There you go. Perfect.
yeah, so dear colleagues, now, thank you, John, and my dear friend Luis. And today my topic is treatment of complex aneurysm. I come from Huashan Hospital, affiliated to Shanghai Fudan University. And last year, we have more than 21,000 cases totally. We have 4 campuses in Shanghai and 1 campus in Fuzhou. So we have, in Shanghai, we have around 800 beds, 40 operating rooms, and we are both WFNS and the ACNS training center. So in my opinion, I know in Europe and in some part of the countries, most the endovascular treatment was performed by radiologists. But in my country, neurosurgeons do a lot of endovascular treatment. Like myself, I'm the hybrid neurosurgeon because we know the anatomy and we can see the aneurysm directly in the operating under the microscope, and we can see the plaques, the calcification of the vessel wall, and the calcification of the aneurysm, the daughter sac, and the perforators from the dome or neck of the aneurysm. And we also can treat the aneurysm not only from the inner cavity of the aneurysm, but also from outside of it. And we also can do a lot of things immediately after disaster coming. We can do clipping, bypass, decompression, drainage, and we also can create the hybrid methods combined with the endovascular treatment and open surgery. And we can give the patients best treatment. So still a lot of complex aneurysm need open surgery, including ruptured basilar blister-like aneurysms, accompanying distal ischemia or partial thrombosis of the aneurysm, ruptured or accompanied by hematoma, complex intervention plan, but for sometimes it's quite easy for open surgery. And irregular shape, acute anger, difficult or impossible for intervention, but sometimes it's quite convenient for open surgery. And various recurrent aneurysms, including after surgery or intervention, involving in important perforators, that kind of perforator couldn't be sacrificed, and including multiple aneurysms. Sometimes we can use the same incision to clip all the aneurysms. And also multiple treatment methods are required, including intervention, surgery, bypass, and chronic occlusion. This is a typical ruptured blister-like aneurysm. It's normally it happened on the upper vessel wall of the ICA C6. So this is this kind of interventional treatment has a high re-rupture rate and poor efficacy, but we can use wrapping and side-by-side fenestrated clipping to form an external stent to make it to prevent its recurrence. So this is a very useful technique. And also we have some large with distal ischemia, sometimes with a partial thrombosis, and unable to clip and interventional treatment directly. Like this aneurysm, you can see this is a very long segment ICA distal end, and you can see the distal ischemia. This is a large or giant aneurysm without a neck, and the inflow tract is at the acute angle to the outflow tract. So this kind of patient, the implantation of the full diverter is almost impossible. And also there are important perforators to be preserved. You can see this is also a partially thrombosed aneurysm. So the distal end and the proximal end looks like a two-part, and the proximal part have some important perforators. We have to keep it intact. So we do the double barrel bypass. You can see after the double barrel bypass, the double barrel bypass was all patent, and replace the blood flow from the MCA distal end. And then we just use several coils to coil the proximal part of the aneurysm. And you can see all the distal big aneurysm was not shown anymore. And all the perforators in M1 segment was protected very well. Sometimes we also can have some giant ruptured aneurysm like this one. It's a very complicated case, and you can see the two branch of the superior trunk and the inferior trunk of the MCA was originated from the dome of the aneurysm. So we did the bypass, also a big STA, one to inferior trunk, one to superior trunk, and then we trapping the aneurysm. So finally, this patient was cured very well. So we can also use hybrid treatment to clipping for the proximal ICA. Normally, this kind of aneurysm, you can see it's a giant ophthalmic artery aneurysm. So we use a balloon catheter to insert in the proximal part of ICA. We don't open the neck to expose the ICA. Then we do the routine craniotomy. I use Professor Yuha's LSO approach, lateral superior orbital approach, and removes the anterior crinoid process. Then we inflate the balloon to block the blood flow from the proximal part of the ICA, and also temporal clip the distal part of the ICA. Then we suction the blood flow of the aneurysm. Then you can see the aneurysm collapse very well. Then we use two fenestrated clip to reshape the vessel cavity and check all the perforators to make sure it's all open. The PCAM. Now you see the vessel was patent. And sometimes we also can encounter some strange shape, very weird angle, like this patient. Although it's a very small aneurysm, but it's a wide neck and the vessel wall involving 270 degree, and in a short distance, the vessel tortured. Also 270 degree. So this kind of interventional treatment would be very difficult. But the clipping is quite easy. You see, this is a aneurysm under the microscope. I use two fenestrated clip relay to reshaping the blood vessel channel like this. So this is a very easy case for open surgery, but difficult for interventional treatment. And this is also a M1 terminal segment giant aneurysm. So you can see this aneurysm was partially calcified, and there's no neck at the aneurysm. So I use 11 clips to reshape the outflow of two inferior trunk and the superior trunk like this. But after 7 years later, the patient have a little bit recurrent. So finally, we put another fluid diverter in it. Now the patient is follow-up result is quite good. So sometimes we also have some aneurysm with severe calcification. So you can see in this kind of condition, the aneurysm clip would be very easy to slip from the dome or neck of the aneurysm. So this kind of condition, we would use the hybrid operating room. So under the intraoperative DSA, we can check the angle and the vessel cavity reshaped by the aneurysm clip. And then you see this is a very good result and very stable after we observed for half an hour. Sometimes, if we have enough space, we can resect the aneurysm and made end-to-end in situ anastomose and wrapping with the dural strip like this. You can see this is a triangle shape aneurysm, and I try to reshaping the vessel cavity, but it's calcified and very difficult. So I remove it and do an end-to-end anastomose, then wrapping with the dural strip like this. To prevent the recurrence of the aneurysm. This is the final result. So sometimes in ruptured aneurysm, sometimes with hematoma, if you use interventional treatment, it should be very difficult. Like this patient, it's a M1 bifurcation aneurysm with a daughter sac. And if you use interventional treatment, you should use Y stent, and it's quite difficult in ruptured stage. And but if you use clipping like this, I use uncurved clip to clip the distal end of the daughter sac, and then use two fenestrated clip to making out scaffold for the fenestrated clips to prevent the recurrence of the aneurysm. So this is a very important technique to prevent recurrence. Sometimes we also have some posterior fossa ruptured pica aneurysm. Sometimes we also need the distal bypass. But in this case, you can see at the neck of the aneurysm, there's a calcify and plaque. So finally, I use 6 clips to reshape the vessel cavity successfully. And sometimes we also can encounter a lot of multiple aneurysm. Like this is a multiple aneurysm. One is a ACAM aneurysm. Another one is a MCA big aneurysm. So we use clips to reshaping the vessel cavity of the MCA. And in ACOM aneurysm, just a curved clip to clip the aneurysm. This is another case of aneurysm can be clipped at the same time with one incision. You can see this is a bilateral PCAM aneurysm. So we use a right side approach, LSO approach. And you can see, although it's a very small aneurysm, but it's the dome of the aneurysm was very thin. This kind of aneurysm is very easy to rupture. You see it's clipped successfully. And the other side, we try to expose the other side aneurysm. Cut the arachnoid membrane, getting more exposed. Then we can see the aneurysm. It's close to the bifurcation of the ICA. Then clip the aneurysm and save the anterior coronoid artery. You see, we use a very small incision and clip bilateral aneurysm. This is another case of MCA aneurysm. You can see it's involved 270 degrees of the vessel wall. And this is, if you use interventional treatment, you should need a Y-shaped stenting. But surgical plan is quite easy. We can use clipping and wrapping technique. And we use, after the clipping, I use a dacron to wrapping the first clip. The second clip, clip the wrapping dacron. So this kind of technique can prevent the recurrence. This is the M2 serpentine aneurysm, very long segment. You can see we use shaping combined with wrapping and forming a metal plus polyester outer cannula. So you see, this is some use of the curved clips and the fenestrated clips relay to reshaping the vessel cavity. And some part, we also use shaping. And you can see the final 2 clips to prevent the compress of the lateral facial vein. I use 2 clips to, I make a hole to the temporal lobe, then to getting the clipping of the aneurysm to prevent the compress of the vein. The vein is very important. And for a long segment aneurysm like this is a giant PCAM aneurysm. And you see, I use multiple fenestrated clip to form angled metal safety belts to preserve the perforators and reduce the recurrence rate. This is a 3 fenestrated clips relay to preserve all the perforators and to reshaping the vessel cavity. And sometimes we also use combined shaping, clipping, and wrapping technique in one aneurysm. Like this is a very complicated MCA aneurysm, very long segment. And under the microscope, you can see the shape of the aneurysm. So at first, I use a small power monopolar to reshape after temporal clips of the proximal M1. We shaping the vessel cavity, the aneurysm dome, use monopolar, bipolar, sorry. Bipolar, and then we use fenestrated clip to shaping the vessel cavity. And at the final part of the aneurysm enlargement of the vessel wall, I use a wrapping technique. So this is the final end of the wrapping. Sometimes we also can use so-called self-healing mechanism. So this is a huge PECA aneurysm involving very important medulla oblongata perforator. You can see this is a medulla oblongata perforator, totally originate from the dome of the aneurysm. In this kind of case, you couldn't clip the aneurysm perfectly, and at the same time, all preserved this kind of small perforator. This is a very fatal perforators. So I use MEP and SCP monitor, and I just clip the outflow of the aneurysm. The MEP and SCP didn't change in a very long time, more than 40 minutes, and still very stable. So I just clip the outflow of the aneurysm, and you can see after 6 months later, the aneurysm totally cured by itself. You can see in the CT angio, there's no aneurysm anymore. So this is after clip the outflow of the aneurysm, actually the energy going through the aneurysm dome was decreased dramatically. And this kind of energy decrease can make the aneurysm shrink until it's achieved total disappearance. But still keep the perforators intact. Sometimes we also can use hybrid treatment combined with the surgical technique and the interventional techniques. like this. This is a giant MCA aneurysm. You can see in the M1 segment, there's a lot of perforators going to the basal ganglion, so we have to preserve it. So I did the bypass, double barrel STA MCA. You can see it's all patent, and the blood flow come back to the M2 segment. And then I coiling the proximal part of the aneurysm, and finally we cured the aneurysm. This is another case. This is a recurrent case after embolization. You can see after, you can see even the, in the vessel cavity, you can see the stent here. And the coils in the vessel wall. I already trapping the aneurysm. It's very hard to remove the coils in the vessel cavity, in the aneurysm dome. So after remove both most the proximal part of the coils, I cut the aneurysm dome. Take out the thrombosis in the vessel, in the aneurysm. Because this is a M1 segment, so we couldn't finally trapping the M1 like this. So we have to reshaping the vessel cavity. So we have to remove the proximal part of the thrombosis. Now you can see the coils. Now, after removing the proximal thrombus, I reshape it, the M1 vessel cavity like this. So it need a proper angle. So I to achieve the proper angle of the vessel cavity, finally I use suture to keep it in a proper angle. So this is the final result. It's quite good. And this is for ophthalmic segment aneurysm. Actually, according to Professor Yuha's data, this segment is quite easy for recurrence. You can see after the clipping, 1 year later, we follow up the angiogram. You can see the recurrence of the aneurysm. So in this spatial segment, the recurrence rate is highest. It's around 20%. So for this kind of treatment, I use further coiling treatment with a stent. So this is a stent plus coiling after clipping. And this is another giant ACAM aneurysm. It's very difficult. And you can see this is a very strange shape, ugly aneurysm. The contralateral A1, there's no A1 from other side. So this is the only feeder for both A2. So this is very difficult to direct clip it and reshaping the vessel cavity. So and intraoperatively, I use 2 fenestrated clip to make the one very big and wide aneurysm dome into 3 parts, 3 chambers. Then I make coiling separately in the hybrid operating room. So finally, you can see 1 year later, it's very stable, and the A2 was kept very well, and there's no recurrence because of the fenestrated clip to prevent the recurrence of the aneurysm. And I already introduced some special techniques combined with using the endovascular and the neurosurgical techniques. And sometimes we also use bypass technique. Bypass technique is a hemodynamic treatment of ICA aneurysms, normally combined with trapping of the aneurysm, trapping with the ICA and the proximal direct occlusion of the ICA, or sometimes combined with progressive proximal occlusion of the ICA. The purpose is to decrease the pressure of the aneurysm wall and keep the blood flow in perforators and keep the blood flow of distal parent artery. Normally, we use 3 kind of grafts. The biggest is the saphenous vein, then the radial artery, and the smallest is STA. So this is our strategy in treating complex aneurysms or some malignant tumor involving related to the ICA. So at first, we should estimate the natural collateral blood flow, and we also making a surgical plan to guarantee the enough blood flow replacement. So 30 minutes balloon occlusion test was a routine for ICA aneurysm. So if the patient tolerates the 30 minutes balloon occlusion test very well, we will do the enhanced balloon occlusion test, which means blood pressure decreased to 30%. If the patient still tolerates very well, this kind of ICA can be sacrificed immediately without any complications. But if the patient couldn't tolerate the blood pressure decrease, we still need a bypass. In this case, we only need STA-MCA double barrel bypass with ICA occlusion. If the patient cannot tolerate 30 minutes balloon occlusion test, we should make a plan for the blood flow replacement. So if the ICA only feeded the same side MCA territory, if the patient is a male, normally the STA was quite big. So we just do the double barrel bypass. If the patient is a female, normally the STA was quite small. So we still need the radial artery transplant. So if the bilateral ICA is quite even, which means STA feeded the same side MCA and the ACA territory. So this kind of patient, we need a radial artery transplant. If it's a dominant side, and which means the ICA feeding the same side hemisphere combined with the contralateral ACA territory. So this kind of patient, normally we can use radial artery combined with STA-MCA double barrel bypass, or sometimes we use saphenous vein to transplant. In some special case, like a malignant tumor involving invading the bilateral ICA, sometimes we also need to sacrifice both side ICA. So this kind of patient, we need a saphenous vein and two double barrel STA-MCA bypass. Like this patient is a nasopharyngeal carcinoma invading the bilateral ICA, so we need to sacrifice the both side ICA. So I use saphenous vein to transplant from ECA to M2 segment. So you can see we need to replace the whole brain's bilateral ICS blood flow. So I use the saphenous vein transplant combined with left side STM's M4 segment double barrel bypass. And after this kind of treatment, you can see I occluded the both side ICA, and the patient blood flow was quite good. It also have some collateral from PCAM. So this patient finally, after removal of the nasopharyngeal carcinoma, the patient still live very well. So this is after the bypass. You can see the 3 bypass feeding the whole hemisphere, whole brain, bilateral hemisphere. So this is the dominant side ICA, which means the ICA feeding the same side hemisphere and the contralateral ACA territory. So this kind of blood flow replacement needs the saphenous vein to transplant. So this is after the saphenous vein bypass, you can see it replaces the dominant side ICA immediately. This is also a high flow bypass. The bilateral ICA was quite even. The ICA feeding the same side hemisphere. So this kind of patient, I also do a saphenous vein transplant. So after the bypass, you can see the blood flow replace the same side hemisphere immediately. This is a medial flow bypass. This is you can see the blood flow of the left side hemisphere still get some collateral from ACAM and the A1, but the A1 was very small. So we should replace the MCA territory. So I use radial artery transplant from ECA to M2 segment. So this is the final result. You see the radial artery replace the MCA territory immediately. This is another case of giant aneurysm at the distal end of ICA and the A1 original part. So after the direct bypass from ECA to M2 segment, I totally clip the M1 ICA. So this is the final result. You can see the blood flow was quite patent, and the patient recovered very well without any symptoms. So this is a low flow bypass, which means we only need a partial replacement of the MCA territory. So normally we do STA double barrel bypass, one in inferior trunk, one in superior trunk of the MCA. So you can see after the double barrel bypass, the STA was replaced the MCA territory immediately. So sometimes we can also use this kind of progressive clip. So the blue one was designed by myself. The red background clip is a Silverstone clip. So this kind of clip is quite difficult to use, and it's hard to know how deep is it's screwed. So using mine clip, you can see it's very easy to catch the ICA. And because the symmetric design of the proximal part of the distal under the distal part, so you can know how wide it's open. So this is the case of ICA aneurysm. So we do the double barrel STA-MCA bypass and combined with this graduate occlusion of the ICA in 7 days. So after 7 days, you can see the double barrel bypass was all patent and the ICA was totally occluded. And at the same time, the ACAM and the PCAM was become larger and feeding the ACA and the partial part of the temporal lobe. So combined with this kind of progressive clip, we make a medium flow bypass into a low flow bypass. So make things much easier. And this is also a new type need to do the bypass. You may notice the very acute angle of the A1 and the M1 from the distal part of the ICA. So this is a ruptured aneurysm case, a giant aneurysm. So you can see at the emergency stage, the local hospital, they do the craniotomy, decompression, and after this kind of treatment, the patient survived. And now we use the same incision as the last operation and use the radioartery to transplant. So this is the intraoperative video. You can see after the bypass. This is the M2 segment. And this is a progressive clip of the ICA. This is the ICG. You can see the blood flow was very patent. So the progressive clip used in this segment is very important because at the first day, we temporal clip of the 70% of the ICA to make sure the pressure gradient from the ICA radioartery to MCA was positive. If you don't partially clip the ICA, actually the pressure gradient may be, especially in M2 segment to this radioartery distal end, may be negative. If it's a negative, which means the pressure balance point in the ground artery, it should be occluded. So this is our strategy for MCA giant aneurysm. So we already published in World Neurosurgery. If you interested, you can download and read our strategy in this kind of segment. This is a type 1 ICA distal end to M1 aneurysm. You can see this kind of patient, we need to replace the whole MCA territory, and at the same time to protect the perforators. So this is a blue occlusion test is positive. Collateral blood flow was not good enough. So we use a radial artery transplant, and we adjust the location of the clip of trapping, and finally we achieved a very safe trapping of the aneurysm, and at the same time to keep the perforators intact. And this is another M1 aneurysm, a very giant one, but we have enough space to clip the proximal side, and at the same time to keep the integrity of the perforators to the basal ganglion. And this is after the radial artery transplant. You can see the radial artery replace the distal blood flow immediately, and trapping with the aneurysm.
Okay, Professor B. Can you hear me?
Yes, yes.
Sorry for the interruption. We have some question, and we want to begin with the roundtable with Dr. Lopez Ibor. Dr. Lopez Ibor, please begin the roundtable. Please.
Okay. I will close my presentation very soon. Okay.
Sorry, Professor.
Okay. So this is another long segment aneurysm. You can see we do the distal MCA, STA MCA double barrel bypass with distal occlusion of the MCA. So this is the final result. Just after 1 week, you can see the aneurysm disappear and the distal bypass was all patent. This is another giant aneurysm of M2 segment. You can see under the microscope, it's so big. And finally, I reshaping the superior trunk very successfully, but this need time. So I do the distal protective bypass at first, then we reshaping the aneurysm. This is another case of superior trunk. I do remove the aneurysm and do end-to-end anastomosis in this segment. Finally, you can see the superior trunk was intact. Another case, distal bypass with a distal clip, a proximal clip. This is a giant M3 aneurysm. So I do the distal bypass combined with distal clipping. So the patient recovered very well. So sometimes we also can make a combined approach for M3 aneurysm. This is a double barrel ST-MCA combined with the coiling of the proximal part of the aneurysm. We just finished in this month. So monitoring of MEP, SEP in aneurysm, especially MCA aneurysm, is very helpful. Sometimes if the radial artery was too short, we can use right GA as a graft. You can see it's much longer than the radial artery. And this is a MCA giant aneurysm. We after the bypass, we clip we trapping the aneurysm immediately. So neurosurgeon should know the advantage of the interventional treatments, and the hybrid neurosurgeon can give the best treatment for different aneurysms. giant or complex aneurysms still need bypass, and we can also create a new hybrid treatment for complex aneurysms. Thank you for your attention, and next year we will host the ISMIN Congress in our hospital. Thank you.
Thank you, Professor. Thank you. Very awesome cases. Dr. Ruiz, please, you can begin the roundtable. We have both approach of this kind of problem in this kind of difficult aneurysm. What do you think about the technical, the endovascular technical and neurosurgery technique?
I think, thank you very much, Professor Binshu. You are the master, the big master of the bypass.
Thank you.
And to learn the complex anastomosis in the brain. I learned with Las Juniors. I work in Paris, I work in Madrid. I know Jasser Hill, Dolan, wherever you want. Okay, I discuss many times. But you are the hands, the Chinese hands. You are a magus, magician, to capacity to your bypassing your patient work. I know many surgeons attempt to the bypass but don't work. You are many measures in this topic, in this webinar, and I don't stop this for one question. I invite you to many sessions. I invited the last week Professor Jacques Moret to occlusion test of the vascular artery. I have 7 cases with a vascular. May I invite you at the same time? It's one idea. The second idea, I thank you for your learning, young doctor, for this technique, because it's totally abandoned around Europe. I don't know in China, I mean, in Europe. I think it's very important the help the patient with the anastomosis. And my one only question, what do you think is possible to treat in the massive ischemia, acute ischemia, in acute phase, to replace the flow, the distal part of M1? What do you think about your experience for this? You are medial cerebral arterial thrombus, and you're going very fast. At the same time, endovascular, and you blah, 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 you place the anastomosis. What do you think from this? Thank you.
Yes, actually, this is a very good question. And personally, I didn't do a lot of this kind of emergency blood flow replacement, especially for because I have so many elective cases, and my days are all full. Like today, I performed 8 cases in my hometown, 4 endovascular treatment for aneurysms, and 3 bypass for moya, and 1 meningioma, giant meningioma removing. So this is a typical day for my job, and I noticed Dr. Walid Abbas, and he is also a professor from Egypt. Walid, you are welcome to join us for discussing. And
how are you?
Hi.
Nice
to see you again. Yeah.
Nice to meet you.
And Walid just visited our hospital, and he observed my work, and he already see a lot of bypass case, I think. And now he already begin his own bypass in Egypt. I'm very happy for that. And actually, my technique is quite simple. So it's easy to learn, and it's easy to perform. If you have the opportunity to treat the acute stroke case within 24 hours, you still have chance to do the blood flow replacement for MCA territory. But the M1 segment, if it's a thrombus, we still need to remove the thrombus. Because if we don't remove the thrombus, the perforators of M1 segment still be occluded. So it can be cause the infarction of the basal ganglion. So if you only replace the distal blood flow, it's not enough.
Sorry. Bin, do you know the Fogarty system to remove the clot?
Yes.
You have possibility with the Fogarty.
Yes.
Time you have Fogarty.
Actually, my friend, Professor Tanikawa from Japan, he do some emergency removing of the thrombus in M1 segment. But personally, I never tried because I don't have this experience yet.
It's a new idea. It's a new idea.
Yes.
Thank you,
Professor. But regarding to my knowledge, some of Japanese and Korean doctors, they do the blood flow replacement immediately after within 24 hours. They told me if it's too late, it's not useful. Yeah.
Please, one thing. I started the unit stroke in Spain, and for me, the neurologists, I'm sorry, in the audience are some neurologists. Neurologists don't understand the neurovascular pathology. Why?
Yes.
Why you wait maximum 8 hours or 10 hours to the middle cerebral artery, and you wait 24 or 48 hours in the vascular artery? It's not the same. Why? This protocol is not good. I think the advance in the treatment of the vascular pathology is the guide sample for you, Juha, Oliver Krona. I please one comment, Professor from Egypt, Walid Abbas. Welcome to this neuro webinar. I like to invite you or whatever you want with Professor Binshu to participate, and many people come to discuss with different doctors and different places. Okay. Dr. Abbas.
Yeah, Dr. Walid, he is also a member of the WFNS vascular committee. Yeah, he is also a very experienced neurosurgeon.
Okay.
Yeah, thank you. Actually, my opinion about stroke is that if it is an acute stage, I think there are not many persons in the world who have experience doing it. Even Professor Tanikawa, we had like a webinar last week, and someone asked him about acute ischemia. And he said now he's not making too much cases because of the endovascular and thrombectomy and stuff like this. So till now, no. I think there is no too much role in acute ischemia or surgery in the time being. I think so.
Yeah.
I am expert from this, but I don't like the thrombectomy because many people, it's very easy. It's very easy to remove. I like Binshu, I like Juha, and the big neurosurgeon. I'm thinking to remove that one clot is not interesting for me. Okay, Professor Ramirez Chacon, Reynaldo, your call, please.
Yes, Professor. Thank you, Dr. Brici. Thank you, Dr. Bing. I have a question. What do you think about the combination of the hybrid technique in giant aneurysms and complex giant aneurysms with the combination of the stent, diverter stent? I mean, I don't have really very true in this because the aneurysm is alive. In this kind of aneurysm, what do you think the combination of the hybrid technique, Dr. Bing? What is your experience? Your experience obviously is great, but what do you think about that?
What is your critical point to endovascular procedure?
Yeah, really, this is a real question.
But you know, I'm a hybrid neurosurgeon. I'm both doing interventional treatment and also doing the open surgery. So I know, you know, one neurosurgeon only have one label. So my label is a bypass. So a lot of even a lot of my Chinese colleagues, they don't know don't know I also do a lot of interventional treatment. So I think the interventional treatment for me is very important because only if you do the interventional treatment, you can understand the hemodynamic changes of the aneurysm. And you can see, actually, I use a lot of hemodynamic principles to treat the aneurysm, like to clip the outflow of the giant PECA. I already showed. This is a very bold decision, you know. some neurosurgeon wouldn't agree my decision, but I am quite I have a lot of confidence because the energy passing through the aneurysm dome is very important. So if we can decrease the energy of the blood flow dramatically, actually the aneurysm wouldn't enlarged, and it have the chance to shrink. And we also do a lot of blood pressure measurement in moya bypass. So we know the decrease of the pressure and the increase of the pressure bypass of the vessels of the MCA networks. So we are quite confident. I'm quite confident for that. So you can see the final result is very satisfied.
Ben, one comment. Where I think the endovascular surgery or open surgery are the same. It's to treat the patient. It's to treat the patient.
Yes.
But the only, for me, for myself, difference is when you have emergency rupture aneurysm or AVM aneurysm or whatever you want. The endovascular procedure is a good treatment to wait to maybe advance to surgical removal of the lesion. Only this. It's not the discussion what is better and better. Both is very good.
Yes.
I don't categoric. You know, the French or American doctor is categoric or orthodoxic. No. I think both. It depends when do you live. It depends who you are, the doctor, your hospital. Most important is the patient. Okay, John. I think it's time, no, to finish, or do you want more?
No, we can go as long as you want. As long as you want.
Thank you, John.
Whatever you want.
And a question, Dr. They question, hematoma can remove surgically, then going the second stage calling? Dr. Day is question asked. I don't understand good the question.
Yeah, I can read. For aneurysm with hematoma, can remove hematoma surgically, then go in for second stage coiling. I think if you already remove the hematoma surgically, and at the same stage, you should do the clipping or shaping the vessel cavity in the same stage. Yeah, not the same second stage for coiling.
Okay,
You should treat the aneurysm immediately, because after removing of the hematoma, actually the pressure surrounding the aneurysm dome was decreased. So it's very easy to re-rupture. So you should treat the aneurysm dome immediately. If you don't have, you couldn't reshaping the vessel cavity very successfully, at least clip the ruptured site immediately. Then you have the second chance to do the coiling.
One question, Lynn. The neurointerventional radiologist think when you packing, half packing, the patient is well. My question is, you open an emergency, when packing an aneurysm, you see the blood flow around the coils. It's not packing. It's not through. The packing is only 80% or 75%. The rest, you are mixture of the blood. It's not a stop. It's only see you close the neck, not the sac.
Yes. Yes. I agree with you. Yes. Especially for the emergency case. Yes.
Yes. But the emergency case is different to the endovascular, to the neurosurgeon, because the emergency case in endovascular, you don't have free to the spasm. And the neurosurgeon, yes. Why is the spasm? The spasm is one protector physiology to non-eruptive aneurysm. Only this. And the endovascular coiling or whatever you want, stenting, is protective. It's not real cure. The only real cure is remove the lesion. I am endovascular. I don't have a big neurosurgeon home for you. No, it's fantastic. Okay.
Okay. Thank you very much, Professor Rees. Today we have to approach very difficult cases, anonymous cases. And
Yo me voy a despedir, que estoy cansado ya.
Okay, Professor. Yes. One question: How can we bring to technology Professor Bean to Mexico and to taste tequila mezcal? Dangerous. It's a very nice invitation for you and Dr. Liz. We need her promote here in Mexico.
I prefer to go into China, Shanghai.
All right.
Yes.
It's more sure because Mexico is very dangerous.
Oh yeah. Right now.
Right now. Okay. I just stopped myself because it's too long for me. Thank you, John. Thank you.
Yeah, okay. Great discussion. Thanks a lot, Ben. It's great
Every
to see
time.
Thank you,
Great
John.
to see you. Great to see
Every
you.
time.
Yeah.
For you. Thank you.
Okay, Louis, thanks for putting it all together. And Ronaldo, thank you for moderating. And Waleed, thank you for coming.
Thank you for your support.
And we hope to turn this into a real round table like you guys did today. This is great having listen to neurosurgeons. I'm sure a lot of the young neurosurgeons get a lot out of this.
In 2 weeks. In 2 weeks.
So we see you in 2 weeks.
One more time.
Okay, Louis. Ben, okay.
Okay.
Ronaldo, bye-bye.
Congratulations. Congratulations, Professor Binsu, everybody.
Thank you so much. Thank you for broadcasting, Dr. Bennett, and goodbye. We said next.